I like to be sharp on time. It's 6 p.m. here in Florida. This is our first session, Wednesdays live, and this is about MSE, midfacial palatal expansion, questions and answers. I have received a lot of questions into direct messages, and I also received messages that you commented under the post. So I'll cover those a little bit later. The main thing that I would like to dedicate this particular session today is about the question that I've been asked a lot of times, and I have providers and patients who reached out to me asking if the so-called part 2 of the treatment can be transferred to another office, or if MSE can be done separately from the second part of the treatment. So let's say the general idea is that the midfacial palatal expansion or the skeletal expansion is done with the use of two main things. It's of course the meniscus assisted expansion, the appliance itself, it's the procedure of expansion, and then it has to be followed by something. So the general question is, can these two be separated? Can these two be separated in time in between providers? And what can be done if a patient decided to undergo MARPE or MSE in one office, and then they want to continue with the treatment at a different location, in a different state, or somewhere closer to their home? So I will be answering this question today, and this is the biggest question for today. I will start with the thing that I am always sharing my own experience, and it's not something that is written in the books. It's something that has been gained over the years, and with trying different techniques, and with making our approach, our airway orthodontic approach, more efficient every single day. My practice is specialized in airway orthodontics. This is what we do every single day. We see patients that we put expanders every day, that we follow up with expansion, that we do clear aligners. And as you know, I'm very into clear aligner treatment. I am a big fan of Invisalign, and we also started and we recently introduced the shape memory aligners, the direct printed aligners in our office. So this is something that I'm super excited about. And now, if we plan maxillary skeletal expansion, it is very important that it has to be, first of all, comfortable for the patient. We know that if we plan maxillary skeletal expansion, it is done for several reasons. First of all, yes, there is a lack of space. There could be a crossbite in the back, like the anatomical predisposition, the anatomical indication for the maxillary skeletal expansion. There are also some breathing issues, like disturbed nasal breathing, some constant congestions, sinus problems. Most patients the patients started approaching us with the problem of sleep apnea, with the problem of not being able to have deep sleep, deep refreshing sleep. They wake up with the feeling of fatigue. So this is something that was shown in the literature to help to be taken care of with the airway treatment. And MSE and MARPE is something that is also being shown to significantly increase the airway volume within nasal passages. So again, when we plan MSE or MARPE, we plan both the top and the bottom. We plan both jaws. And when we start doing MARPE or MSE, this is of course a slow protocol. This is of course something that we cannot rush with to avoid any unwanted movements. This is something that we have to complement with the lower jaw movements at the same time, because as we start with the maxillary skeletal expansion, maxilla, even with the slow protocol, it expands faster than any type of mandibular movement can follow. And we follow, in particular, in my protocol, we always start with aligners on the lower jaw simultaneously with doing the expansion on the top. First, this helps with the sometimes unpleasant and uncomfortable movements that patients experience with expansion on the upper, because we can see that the occlusion changes, that the bite becomes less comfortable, and it's less comfortable to chew and less comfortable to find the best position for the mandibles. So aligners help with that. Aligners also help to upright those molars that are significantly lingually inclined. So these are types of movements that are being taken care of from the very beginning. And again, when we start with the MARPE and why it cannot be separated, the first reason I just pointed out, that was the simultaneous movement between the top and the bottom. The second reason is that, of course, there are some asymmetries, and I posted on the broadcast channel that we just started a couple days ago that asymmetries usually are unrecognized or unseen or undiagnosed from the very beginning. It's not that MARPE or MSE produces a lot of asymmetry. No, it's just in most of the cases, I would say in 70, maybe 80% of the cases, those asymmetries are already present. And MARPE or MSE with expansion, it just makes it more visible, because this is the area that is just psychologically more being paid attention to, and more is becoming more visible because of the spaces, because of the appearance, and the changes to appearance are drastic with maxillary skeletal expansion. Appearance, the face changes in a better way. The face changes with the cheekbones becoming more pronounced. So this is something that can also create the point of attention from the surrounding people, from friends and from relatives, and this can also bring some attention and to emphasize that asymmetry that was not diagnosed. So the asymmetry has to be diagnosed and pointed out from the very beginning, and that has to be taken care of during treatment planning. So usually, if there is a severe asymmetry, an asymmetry is usually seen where the maxillary where the cant of the maxilla is tilted to one side. So that also moves the mandible to the opposite side, and that also creates the drift of the chin, and that also brings more asymmetry, so-called percepted asymmetry, not the actual one, when the expansion is done. So in order to reduce that, in order to take care of that, it has to be discussed prior to putting the appliance in, that some measures will be applied in order to correct that asymmetry. And usually that asymmetry is taken care with asymmetric or one side or unilateral intrusion that we do just to correct that cant of the maxillary plane and to move the mandible and then to put it centered. As we know, maxillary expansion also produces some physiologic movement of the lower jaw. The same way the lower jaw becomes more centered, it becomes more so-called protruded because of those contacts of the molars that unlock it, that let it go forward naturally in a natural and physiologic way. Also, there is a very big thing that has to be also taken into account. When we do maxillary expansion, the biggest question is how far we can go and what are the limits, and can we overexpand? These are all very good questions. The biggest thing about it, especially in our experience, in my practice, what I've noticed, and we do a lot of research on that, we do comparisons between before and after, and we see how the maxilla, how the bones behave. What we've noticed is that there is a certain degree of expansion, and at certain point, at certain number of millimeters of expansion, we see additional changes to the face, additional changes to the bite, additional changes to the facial bones that produce even more pronounced effect for breathing, for arrangement of the nasal passages and the surrounding bones, and the positioning of the cheekbones. So in our practice, and I don't want to dive into particular numbers, but we have expanded in our practice up to 10, 11 millimeters of pure skeletal expansion, which is a centimeter, which is almost the width of my index finger, which is a lot. And during that expansion, if we see a lot of changes that occur around the facial bones, that occur in between the sutures, in between the connections between different bones. So that is also related to the degree of expansion. And this treatment cannot be transferred to a different provider. This treatment has the degree of expansion has to be within the hands of both the patient and the provider. The provider has to tell the patient of what to expect with different types of different degree of expansion, what changes will occur, and it's to the patient to choose if they want to go over a certain degree of expansion. Now I will go back to the questions that you posted, to the questions that you sent to me. One of the questions was, can I still get MSE if only I have 2 upper wisdom teeth and the bottom that not have erupted? Wisdom teeth are not something that restricts the maxillary expansion. As we know, crowding exists not only in the anterior or front regions, crowding also exists in the posterior or back regions, and molar crowding is a very frequent finding. Why? Because there is a certain amount of bone, and molars have to fit within a certain amount of bone. Even distalization, even backward movement of the molars is also restricted by the bone. You cannot move the molars backwards beyond what the bone is and what are the limits of the bone. So going back to that question, yes, we can do expansion, we can increase the width of the maxillary arch, and I would say intermaxillary width with MSE or MARPE, having wisdom teeth in. In terms of the inconsistency between the number of molars on the top and the bottom, that is a different question. That is a question related to the other aspect of the orofacial area, to the TMJ. I also vote for having equal number of molars between both sides, between the left side and the right side. And as we know, if there is an erupted upper molar, it will be erupting throughout life, and it will be trying to touch or to approach the lower arch, at least the gum level, and it will constantly extrude throughout life. So that is not a good thing in terms of the health of the TMJ, and so that is why it has to be monitored. And if there is such a tendency, if this molar, if the third molar is not restricted from eruption, then it has to be taken care. Also, we have a question of how to expand our upper jaw in adults over 25 years, and especially in male patients. The protocols that we have in our practice, we do expand. There is no age limit unless there are certain contraindications. The oldest patient in our practice is the patient in their 50s, is 55-year-old male patient. We do expand both males and females. We do expand we do use meniscus-assisted palatal expanders sometimes starting 8 and 9 years old. Sometimes when the upper jaw, when the maxillary arch, when the intermaxillary width is so constricted, is so small, then that the bone has grown to the extent that there is no actual surface for the tongue positioning, for the correct area or spacing inside the oral cavity. Yes, the meniscus-assisted palatal expansion has to be used in those cases, and we do use that, not frequently, but there are instances that we use these appliances in 8 and 9-year-old kids. But going back to the to the males and to adults, I personally use piezocorticotomy in all adult patients both males and female patients, for the reason that piezocardicotomy allows for more even, symmetrical, balanced expansion, more predictable expansion. We do have a specific timeline that we know the suture will separate, and we always tell our patients that after you make your first turn, you will expect the diastema or the space to open within this specific period of time, and we name the number of days within which to expect that suture opening. That is mostly because we use piezocardicotomy. We do have almost the same range of when the suture opens in teenagers, in kids, when we do this procedure without piezocardicotomy, so it's very much predictable in both. The piezo is done with the special CBCT intraoral scan based guide, piezocardicotomy guide, that I personally plan in a 3D software based on the position of the nasal septum, based on the thickness of the bone, based on the depth of the piezo-scission. So that is done very accurately and precisely for every single patient before they undergo this procedure. So when we do the procedure, we do use the piezo guide. We then position the appliance. The whole procedure takes around, on average, everywhere from, I would say, 25 maybe to 30, 35 minutes in total. The other 10 minutes is just about maybe explaining what to expect and what's going to happen within the next couple weeks. We do see patients every 3 weeks after the initial placement and the initial turn. And there is a specific, again, we always work on refining our protocol, our airway protocol with MARPE appliances to make this procedure as predictable as possible, and to create the environment for the patients when they know what to expect, when they trust, and when they are confident in the treatment that they get and in their provider, of course. One of the questions is also regarding the is there anything that we recommend in conjunction with the MARPE and piezo and the palatal expansion? Yes, we do recommend adding myofunctional therapy closer to removing of the appliance. Usually the protocol is that we do expand over the period of 2 to 3 months. On average, it's 10 to 12 weeks, case by case. But after the active expansion, we do secure the appliance. We keep that appliance for additional 6 to 7 months, depending on if we need to use that appliance for some additional purposes. And after we're done with expansion, after the appliance has served its purpose for keeping the bone, keeping the expansion, we remove the appliance. So closer to that period, we recommend starting the myofunctional therapy. Myofunctional therapy serves several purposes. As we all know, with the maxillary expansion, there's also, so that is done to increase the space inside the oral cavity, to position the tongue correctly, and to retreat the tongue, of how the tongue has to be positioned, of how the tongue has to function. And in order to have the tongue be prepared for that, the myofunctional therapy has to start a little bit earlier than the actual removal of the appliance. And when we remove the appliance, this is the time when when I would say maybe 70% of the myofunctional therapy occurs, and this is the best time to when the actual space for the tongue has regained. When the appliance is removed, the tongue can go as high and be as flat against the palatal mucosa as possible. So that is something that we recommend as an adjunct. Also, if you do undergo the osteopathic or craniosacral therapy, the best time to add it to the treatment is when the actual expansion is over, when the bones are no longer moving. And I would say that it's going to be, if we expand for a period of 3 months, let's say roughly, then another 2 months will be the time when the bones will be settling against each other. So imagine with the maxillary expansion, all the bones of the facial skeleton, they have sutures disengaged. So they are almost floating against each other. And all the loads that come through the bite, through occlusion, through outer forces, they tend to somehow change the position of the bones, the relationship between the those contacting surfaces of the sutures. So even the occlusion, that plays a great role in how the sutures will be reacting to the maxillary expansion and how everything will be settling against each other. So 2 months after is the best time when the bones start to settle, when the bone in between the two halves of the maxillary processes starts to harden. It becomes stickier. The suture fuses. So that is the best time to jump in, to kick in with that craniosacral and osteopathic manipulations on the head and the neck, because all three, the head, the neck, the tongue, the mandibular position, are all related, but the final result cannot be justified until the mandible is finally positioned. So that happens only closer to the end of the treatment. In our practice, treatment usually lasts for about everywhere 18 to maybe 22 months. On average, it's 18 months. So we do not expect final mandibular positioning until maybe 14 months from the beginning of treatment. And as I've mentioned at the very beginning, we start working on the mandible from the very beginning. So it's not that we do treatment on maxilla, then wait, and then we start doing something on the mandible. No, we do everything at the same time, maxilla and mandible from the very beginning, even though we're not using any specific expansion devices on the mandibular arch. Maybe in very rare occasions, or maybe on children, but they do not have any mini screws or anything like that. That is our first session.